Thanks, Huey, and thanks for organizing this again. This is a really cool event, and I hope that we can continue to do this going into the future. So I've thinned the crew out. That's good news for me. So we're going to be talking about heart failure and congenital heart disease, as Huey alluded to. It's going to be the kind of same basic talk where we'll go through some epidemiology, move on to how we diagnose heart failure in adult congenital heart disease patients, kind of go over the scope of the problem in this group of people, and then review what therapies there are in terms of conventional medical therapy, and then finally end with what type of advanced therapies are available. Now, you always have to start with a sarcastic superhero slide, both to get people's attention and because it must work. I mean, how else can you explain the remarkable success of the film Deadpool? I see you out there. You're just here for the CME, aren't you? All right. So actually, you should care about adult congenital heart disease because the numbers are increasing, and I'm sure you've seen slides like this about 1,000 times. And these data almost always come from Canada because since they have a single-payer system, they actually track their patients throughout their life. And if you look at the purple, which are the pediatric patients, and the red, which are the adult patients, in the top graph, it is all patients with congenital heart disease. The bottom is only those with complex congenital heart disease. You can see that since 2000, the number of adults with congenital heart disease outnumbers the number of kids. And the numbers have continued to grow such that there's been an almost doubling of the numbers of adults with congenital heart disease, both complex and overall, from between 2000 and 2010. And why is this? Now, a certain proportion of it is due to superior imaging technology and the fact that we're now identifying previously clinically silent lesions. But the majority of it is due to the fact that our pediatric cardiac colleagues are doing such a great job of taking care of these patients. And this is demonstrated again in data from Canada. This is Paul Carey's work. If you look at this, I'll orient you. This is a population bar indicating when people die with congenital heart disease. The yellow bars indicate people with congenital heart disease, and the black line is actually the general population in Quebec, Canada. And you can see in the mid-'80s, compared to the general population, people with congenital heart disease were dying far earlier, largely in childhood. But as recently as the early 2000s, the population of congenital heart disease have a life expectancy not dissimilar to that of the general population in which they live. So they're living longer. And that's the reason why, although nature isn't making any more of these patients, there are a lot more years between 18 and death than there are between 0 and 18. And so the numbers are increasing. Now, you've got a population that's growing of people with chronic heart disease. Some of them are going to get heart failure. So how do we diagnose heart failure? And I got to tell you, I have absolutely no idea. Anybody who tells you they have an idea, there's no way that they're telling you the truth. And a part of the reason for that is what Tom alluded to earlier. If we define heart failure as an incapacity of the heart to augment its output to meet the needs of daily life, some congenital lesions have profoundly depressed capacity to augment cardiac output, even at baseline. This is data from the Great Ormond Street Hospital in London. And you can see that people with more complex lesions, Eisenmenger syndrome, Fontan, this is compared to age and sex match controls. Even walkie-talkie coming in off the street, these people have 60% of what they should have in terms of their capacity to augment cardiac output. So it makes defining heart failure very difficult. And as a result, the studies that have been published up until now have defined heart failure in any number of different ways. Anything from everybody with ACHD has congestive heart failure, to fairly complicated combinations of biomarkers and symptoms to describe heart failure. And some of this may have to do with what ended up getting them statistically significant results on their particular manuscript. What we're going to be looking at here, for the sake of clarity and all the things that I'm going to be talking about, is the easiest definition and that's most reproducible, which is somebody who gets admitted to the hospital and has a discharge diagnosis of congestive heart failure. So if we define congestive heart failure and congenital heart disease in that way, how big is the problem? Are we talking about like the moon, or are we talking about like an elephant? And which of those is actually bigger? It's actually a fairly sizable problem. So let's start back at the beginning. Hospitalization rate in congenital heart disease in general, again, using data from Canada, is greater than in the general population. Even among patients with simple lesions, the hospitalization rate is twofold that of the general population, and it's over threefold that of the general population if you're only looking at those with complex congenital heart disease. And predictably, the extra hospitalizations are due to cardiac disease. In this study we did at Washington University, looking at people with complex lesions, transposition, tetralogy, single ventricles, and comparing their hospitalization rate by discharge diagnosis with the general US population, you can see that they're hospitalized far more frequently, and the majority of the excess is attributable to cardiac causes. I mean, that's exactly what you'd expect, right? They're getting admitted for heart failure, arrhythmia, and for repeat surgical procedures that are necessary as their original operations deteriorate. And the rate of hospitalization or of developing congestive heart failure increases over the lifespan of somebody with congenital heart disease, regardless of what diagnosis they have, based on this data from Germany, where they have a large database in tracking congenital heart disease patients. And so, given that the population of congenital heart disease patients is enlarging and aging, it's not a surprise that since 1998, between 1998 and 2005, there's been an almost doubling of the number of heart failure-related hospitalizations in the ACHD population. And that makes a big difference, right? We all know why we care about hospitalizations. Cost of care is directly linked to hospitalizations. We looked at this, in this analysis, we looked at the cost of inpatient care for all adults with congenital heart disease in the United States using the Healthcare Cost and Utilization Project in the United States. And the primary driver of inpatient cost of care on an annual basis is rehospitalizations. The other reason why we didn't look at hospitalizations in general is because in that database we're blind to people who don't get hospitalized. But let's focus on hospitalizations for a second, rehospitalizations for a second. Who gets rehospitalized? Well, if you're hospitalized once with congestive heart failure, chances are you're going to get hospitalized again. And when you get rehospitalized, the most common diagnosis at the time of rehospitalization is congestive heart failure. So once you've been hospitalized once with it, you're going to get hospitalized again with it, and rehospitalizations are a primary driver of cost of care in adult congenital heart disease on the inpatient side. But lest we be deemed callous for looking only at the economic side of things, once you've been hospitalized once for congestive heart failure, based on this data from the Netherlands, you have a very high probability of dying over the ensuing 3 years, up to 25%. These are people who were otherwise doing okay, at least they thought. And we know that congestive heart failure is the primary cause of mortality in congenital heart disease, both based on the Concord registry from the Netherlands, shown here, as well as from this large population registry in Germany that I alluded to earlier. Great. So we have this growing group of patients who have this terrible, costly problem that affects their longevity. What are we going to do about it? What treatments do we have? And here again, we're kind of at a loss. So you're going to notice that this is a recurrent theme when we're talking about adult congenital heart disease, the kind of almost complete lack of data that we have for almost everything. Now, the professional organizations in both the United States and Europe recognize that this is a problem. And they released competing guideline statements just within the past 12 months saying, this is very important, but we have no idea what we should do about it. They basically said, well, you know, here are the things you can use to diagnose it, but in reality, it's kind of like the color red. You know it when you see it. It's very difficult to define it, and otherwise they weren't able to come up with anything in terms of recommendations for therapies. And the reason for that is because there's just no good data. This is an incomplete but a reasonable list of the trials that have been done looking at the efficacy of modern neurohumoral modulation in congenital heart disease patients. And as you can see, if you look kind of at the far right-hand column, the vast majority of these interventions have had no benefit, and the ones that do show a benefit had, like 7 patients or 8 patients. So that's just screaming type 1 error and publication bias to me. So basically, we don't have enough data to use these therapies. We use them, but it's really not based on any concrete evidence. The only intervention that has been demonstrated time and again to improve outcomes in congenital heart disease is referral to specialized congenital heart disease care. And the reason for that is probably because of what Tom was talking about, that adult congenital providers or pediatric congenital heart disease providers, they know the characteristic and stereotypical ways in which these prior surgical repairs will deteriorate with time. They know the types of arrhythmias that these patients are prone to having. And so all of these factors which could be contributing to the manifestation of heart failure and that are potentially reversible, they're familiar to adult congenital providers. And I think that's probably what's responsible for this gap. So let's say somebody's seen an adult congenital provider and they're getting sicker and sicker. How do we know when it's that time? How do we know when it's time to refer the patient for advanced care, mechanical assists, transplant? Its timing is everything, right? And that's not so easy either, right? Traditionally, if we're talking about people with normal cardiac anatomy, we use VO2 max criteria. You know, once they have contractile dysfunction and a limitation in their VO2 max below a certain threshold attributable to their heart, we refer them for transplant. But as I showed you earlier, exercise tolerances are so variable and so on the average low, even at baseline in congenital heart disease population, that's not going to be a great criteria for use for referral. How about biomarkers? There's all sorts of excitement about biomarkers. Well, this is a summary, again, not exhaustive, but reasonable, of the biomarker trials that have been used that have been investigated in congenital heart disease. And it does appear that, for the most part, the circles mean that there was a difference, the X's mean there wasn't. I don't want you to memorize the whole thing. The upshot of this is to demonstrate that biomarkers that are demonstrably abnormal in patients with normal cardiac anatomy and which convey adverse prognosis or associated with an adverse prognosis are similarly predictable in congenital heart disease patients. The problem with these biomarkers is that they're variable and they're dependent on whether the person's been taking their medicines and whether they ate at a Chinese buffet and all sorts of other variables which you can't control for and which can vary from time to time. And so when you're talking about a major decision like referring somebody for advanced care, this in isolation is not going to be adequate. Similarly, there are clinical models that have been used in the group of patients with normal cardiac anatomy to determine timing or prognosis with heart failure, which might be useful in adult congenital heart disease as well. And this group actually looked retrospectively at a group of congenital heart disease patients and applied the Seattle heart failure measure to them to see if it was similarly predictive of prognosis in adult congenital heart disease as it was in patients with normal cardiac anatomy. And it turns out it actually did do a reasonably good job. If you look at this, oops, you saw a preview of my next joke. So if you look at the solid line, which are people who scored poorly, those who had a less than 70% chance of survival at 5 years, they had higher probability of mortality, of combined endpoint, which I don't know why they put it in this order, of cardiovascular hospitalization, and no statistically significant difference in terms of arrhythmia. So it does seem that this questionnaire is a relatively sensitive predictor of heart failure-related hospitalization and mortality and could be used for referral for transplant. But in an event which can only be explained by the drive to publication at academic institutions in the United States, the same group, using these same data, not 12 months later, published another article saying that this questionnaire was inadequately sensitive to be clinically useful in identifying patients who should be referred for advanced cardiac care. So the reality is it's probably going to be a combination of biomarkers, clinical factors, and probably it's going to be lesion-specific that we're going to need to use to determine timing for referral for transplant. Now, in spite of the lack of good data, like I said before, you know the color red when you see it, although you may have a hard time defining it, people do get referred for advanced care. So how do? Do they all just, die? I mean, what are outcomes like in people who get referred for advanced care who are born with congenital heart disease. And actually, the outcomes are pretty good. For a long time, people thought that outcomes would be worse because they said, you know, well, they've had all these surgeries before, they're allosensitized, they're going to be prone to rejection. The surgical operation is going to be so much more difficult because they've had prior sternotomies, they're going to have to dig through a bunch of scar tissue, you're going to have prolonged ischemic times, and then the connections are going to be all screwed up. You're going to have great big extra tissue that you collect on the harvest on the donor organ, and it's just going to be a mess. But actually, they do pretty well. So if we're looking, now this is, I know, a busy slide, and you'll have to apologize, I'll have to apologize for it, but it actually gives data that's very important. So I'm going to go through it a little bit more slowly. So what we're looking at here, and just pay attention to the big black splotches, because that's really what we're getting at. This is a meta-analysis of studies that have been done looking at UNOS transplants in the United States, and they've divided them by Fontan patients, which are the top black splotch, those who have congenital heart disease without a Fontan, which is the middle black splotch, and the bottom black splotch, which is just those two sums together. From A, B, C, D, this is 30-day, 1-year, 5-year, and 10-year rates of mortality. And you can see that up front, there is a little bit of a detriment in the ACHD population, and it's completely attributable to these patients who have a Fontan circulation. Patients who have ACHD but without a Fontan circulation, early outcomes are identical. Once you clear the first 30 days, this difference in the Fontan patients is no longer statistically significant compared to the general population. And if you get out to 5 and 10 years, there's actually a trend towards better outcomes in adult congenital heart disease patients who are transplanted as compared with the general population. Is there a difference in what these patients are dying of compared to the general population? Yeah, it's a little different, and they're all predictable. So let's start with the stuff that's actually statistically significant. So it turns out younger patients, i.e. adult congenital heart disease patients, when they get transplanted, don't die of malignancy as commonly as people who are older, i.e. those who have general heart failure. They are more prone to early graft dysfunction, hemorrhage, and stroke in the perioperative period, and that probably relates to the complexity of the surgical procedure. No statistically significant difference in the rate of infection, although there's a trend towards decreased rates in adult congenital heart disease patients. And interestingly, looking at these last two things, the rate of rejection and of allograft vasculopathy is no different and maybe even trending lower in spite of these concerns about allosensitization. It's not a problem. The biggest problem for adults with congenital heart disease who are facing transplantation is the waiting list. They sit on the waiting list and they die at higher rates than their counterparts with normal cardiac anatomy. And there is an analysis that recently came out in the Journal of Heart and Lung Transplant where they looked at this and investigated a little bit further. And I'll orient you to these graphs because they're a little bit not clear. So this is probability of dying on the transplant list, and this is the probability of delisting due to clinical worsening. The colors, blue is 1A, red is 1B, gray is 2. The dotted line is the general population, and the solid line is adult congenital heart disease patients. And as you can see, the probability of death or delisting due to clinical worsening among congenital heart disease patients is far higher than the general population, and it's exclusively in those listed as 1A. Exclusively. Those listed 1B and those listed 2, there's no statistically significant difference. This means the sickest patients are waiting too long. And I think that a lot of adult congenital providers knew this, that by the time our patients who are 23 or 30 years old are decompensating to the point where they're listed 1A, they're a lot sicker than when somebody who's got conventional heart disease and is 65 years old is on that edge. They've kind of gone through a lot more. So what can we do to solve this problem? Well, I would propose, for your consumption, that we should be using a new technology that is currently underused in adult congenital heart disease patients, and that's namely ventricular assist devices. And this is new data which has never been seen before. That will be hopefully published within the next couple months, where we actually looked at the Intermax database and we looked at the differences in survival and outcomes in the patients who got a ventricular, any kind of mechanical assist and had congenital heart disease versus those who did not have congenital heart disease. The non-congenital heart disease patients are in red, congenital heart disease patients are in blue. You can see that for all mechanical assist, rates of mortality are higher in congenital heart disease. However, this is almost exclusively attributable to people who get either BiVads or total artificial hearts. If you're looking at just systemic ventricular support, outcomes no different in congenital heart disease patients compared to non-congenital heart disease patients. Whereas if you look at BiVads or total artificial hearts, I mean, we're talking about, yeah, this one guy out here who had I guess he did poorly. So we're talking about very small numbers, but this is where all of the difference comes from. So actually, patients with congenital heart disease, in spite of their increased complexity, seem to do better. You think that ventricular morphology and where you're going to put the inflow cannula and all this other stuff, you think that's going to make a difference? Nope. Look at those with a systemic morphologic right ventricle, systemic morphologic left ventricle, or single ventricle, no difference in outcomes after ventricular assist device. The advantage of ventricular assist device is that once you've got one, you have 30 days of stable supported 1A time, and if you have any device malfunction, you automatically get upgraded to 1A. So I think this could be one route, even within the current system, for improving waiting list outcomes in adult congenital heart disease patients. All right, so now I get off my soapbox now. In conclusion, heart failure is common in congenital heart disease. And we just don't have any data on conventional neurohumoral modulation in this population. May work. We all do it, like Tom said, but there's no data to support it. Heart transplant and VAD are good options in congenital heart disease patients who are at the end of the road. And really, referral to an adult congenital heart disease specialist is fundamentally important to reverse the reversible causes of heart failure before referral for advanced care.